Good afternoon. Welcome to the 3 months progress report. My name is Bálint Zsombor Sárai. My PhD thesis is the daily aspects of oral medicine. I am a first-year PhD student and a clinical dentist in the Department of Community Dentistry. My supervisor is Orsolya Német, and my SMS is Kata Kelemen. My mission is to make a positive difference in all patients' lives. According to my vision, I want to achieve affordable and good oral health for everyone. Here you can see my first 2 ongoing projects. My first topic is investigating the efficacy of steroid and calcineurin inhibitor treatment in Oral Lichen Planus, what will be a systematic review and a network meta-analysis. The project started in September. The co-investigator is Eli Guttmacher. Regarding the pathogenesis, Oral Lichen Planus is a chronic inflammatory disease of the oral mucosa. Because of the sensitivity, patients at first avoid spicy food. Later, they can eat only neutral taste food, and they can drink only warm water. The striae cause tension in the mucosa, what makes a constant discomfort. The disease is not a life-threatening disease, but it can decrease the patient's quality of life for decades. Over time, social anxiety and depression can also develop. Speaking of its treatment, there is no gold standard. Topical steroids are used in first line. However, these medicaments have numerous side effects, locally and systematically. Recently, there are new drugs, calcineurin inhibitors, which reduce the concentration of pro-inflammatory cytokines locally. Our aim is to compare the most frequent treatments to get the most effective result. Our clinical question is, which is the more effective treatment, topical steroids or calcineurin inhibitors in patients suffering from Oral Lichen Planus? Our population is based on the PICO framework, patients with OLP. We want to compare calcineurin inhibitors, topical steroids, and placebo to each other to get the outcomes of morphology, severity of pain, and adverse effects to investigate the safety. Our hypothesis is topical calcineurin inhibitor treatment has better efficiency and longer effective treatment period than measured in topical steroid therapy for OLP. The clinical implication is to give a guidance to dentists to choose the most effective treatment. Our systematic search was conducted in November in 4 databases. We got over 4,000 results. My first key article has the strength of detailed data collection with photographic documentation and the computer-generated randomization. However, they measured small sample sizes from a not representative population. Brennan and colleagues' study had also randomized population from what was representative and had a detailed side effect report. However, they had a short follow-up period, and their study wasn't conclusive at the end. My third article had a detailed data collection, and the study design was presented accurately, in contrast with small sample sizes and lost data due to failed reports. As I mentioned before, we got over 4,000 articles from the systematic search. After duplicate removal, we got around 3,000 results. After the title abstract selection, we got 64 eligible articles to do the full text selection, what we are working on now. My second topic is investigating the pre-diagnostic accuracy of autofluorescence visualization on oral premalignant lesions, which will be systematic review and a meta-analysis. Every year, 400,000 estimated new cases of oral cancer are diagnosed worldwide. Half of these new cases are diagnosed in an advanced stage. That's why the 5-year survival rate is around 40%. Conventional oral examination method is used for the detection. However, it has some limitations, such as the observer's experience and the level of knowledge. Luckily, there is a new detection method called optical biopsy system using the interaction between the emitted light and the tissue. When emitting the oral cavity with blue light, normal tissue absorbs energy and re-emits a longer wavelength, green light, in contrast with dysplastic areas which appear darker. According to that, our aim is to find the clinically most relevant detection method. Our clinical question is, does autofluorescence visualization method be more accurate than conventional oral examination for detecting oral premalignant lesions? We want to compare AFV to the conventional method in a population with oral premalignant lesions with reference of histopathological assessment to get the specificity and the sensitivity of autofluorescence visualization. Our hypothesis is autofluorescence visualization is more accurate than conventional oral examination in detecting oral premalignant lesions. The clinical implication is to establish the possibility of early detection of premalignant lesions. Our preliminary search was conducted in 4 databases. I found 3 key articles with the comparison of the conventional and the new method, with the reference of histopathological assessment and the outcomes of sensitivity and specificity of autofluorescence visualization. I also found 2 previous meta-analyses and the Prospero registration from 2021, which is ongoing. Speaking of my aims, I want to finish my first project in September 2024 and my second project in November 2024. Let me end my presentation with a quote by Katinka Hosszú: "Success is an achievement and not a final destination." Thank you for your attention.
Thank you for your presentation. Do you know if there's any difference between the types of Oral Lichen Planus and the response to the calcineurin or the steroid inhibitors?
Thank you for the question. There are differences. Until now, calcineurin inhibitors were used after for the lesions no responsive for steroid therapy.
Thank you.
Thank you.
I would like to congratulate for your presentation, and I have a question about that. Do you plan any subgrouping? Because we know that there are many causes of the Oral Lichen Planus, or would you like to investigate all together?
Thank you for the question. Regarding Oral Lichen Planus, we don't plan to do subgrouping. Regarding the medication method, we are planning to subgroup into 2 subgroups: patches and ointments.
Thank you.
Thank you.
So very good presentation and a great topic. I have a question in your first project. So in the intervention and control, there was a placebo group. So do you have any data yet from the key articles if that group of patients take any usual care medication for their pain, for example? And if yes, will that impact your outcomes as a confounding factor?
Thank you for your question. If I understood, there was no data about the painkillers they used, or sorry, may you?
Okay, but if the placebo group doesn't treat his or their pain or something, then is it ethical if we treat only with placebo those patients?
It was a double-blind. Was a double-blind investigation. I don't know if it's ethical or not.
Okay, thank you very much.
And congratulations for your presentation. I have only one question according to the first project. You mentioned that one of the outcomes is the morphology. And how did they measure in the articles the morphology of this lesion?
Thank you for the question. There is a 6-grade scale to measure objectively the morphology, which is based on the lesion size and the appearance of the lesion.
Okay, thank you very much.
Thank you.
Well, if I may have a question, nobody else is having one. In the title abstract selection, your Cohen's kappa came out as 0.48. What happened and how did you fix it?
Yeah, thank you for the question. There was a misunderstanding with my co-investigator. I presented him lately that we don't want to include studies with mouse rinses for the treatment of oral lichen planus. And I excluded them, and he included them.
So then did you repeat the selection?
Yeah,
And then what was the final result, the real Cohen's kappa then?
we didn't calculate it yet.